everybody. I would like to introduce Dr. Paul Kleberg. Dr. Kleberg is a meaningful use expert. He's the Chief Medical Information Officer for Stratus Health and the Clinical Director for KHA REACH and the Regional Extension Center for Minnesota and North Dakota. He has led the ONC Resource Center Meaningful Use Community of Practice, which provides support to other extension centers. Dr. Kleberg is the board chair for HIMSS, is an ex officio member for the Minnesota HIMSS Board, serves on the Minnesota Academy of Family Physicians Foundation Board, and has been a family physician and IT professional for more than 20 years. Welcome, Dr. Kleberg.
Thank you, Candy. And good afternoon, everybody. This time we're going to talk about the changes to Stage 1 and Stage 2. So let me get that going here on the slide. Good. So again, our objective today is just to provide an overview of Stages 1 and 2, also give you a framework for collecting feedback to the proposed rule, and enable you to provide that feedback to CMS because, again, as I've mentioned in previous, they do the best job of making the rules the way they believe is appropriate, but it really takes feedback from those of us in the field to help them understand how it really happens out in the community. So again, this presentation is done by the Lake Superior Quality Innovation Network. That is composed of 3 quality improvement organizations, MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. And we work together to improve health care for Medicare consumers. We share best practices, and also our desire is to maximize the efficiency of care delivery. Again, this is a review. Meaningful use, the whole idea behind meaningful use was to first get people to Stage 1 where they put their hands on a computer. Stage 2 was supposed to be about advanced clinical processes, and 3 was about improving outcomes. And this is all brought about by the HITECH Act that was passed at the end of 2009 that just basically stated 3 things. Number 1, the use of certified EHR technology in a meaningful manner, the exchange of health information, and the submission of quality data for care improvement. Those 3 bullets are the things that are required, and those 3 things are what enable the incentives, and for those who don't choose to do it, will also bring about some of the payment adjustments. This slide here has the link to the HTML version of the document that was released. I prefer the HTML version because it's very easy to select the paragraph within it. You'll see a little ribbon on the right-hand side, and you can copy the URL that would bring you to that exact place in the document. So if you're wishing to share in the document to someone else where that information is included, you can do that. And any of the federal documents that are actually on this website, federalregister.gov, allow you to be able to do that. Comments for the proposed changes to Stage 1 and Stage 2 are due on June 15th. And there's a link here where you can submit those comments. You can either type them out or submit a PDF document or a Word document and upload it to that particular site. There are multiple ways you can do it. You can also send it via mail if you wish to, or hand deliver if you live in the neighborhood. So just as a review, there is a 90-day reporting period in 2015. This is the proposed timeline, and they are proposing 90 days in 2015. Providers in 2015 will do meaningful use Stage 2 with some additional exemptions. So essentially, they're changing the format of all of the requirements for meaningful use for Stage 1 and Stage 2 to fit the Stage 3 architecture. And we'll show you that in a moment. But what they're doing for those who would have been attesting to Stage 1, at least in 2015, they're giving you an exemption for those menu items that you had not decided to do. So again, in 2015, you'd still be able to do the meaningful use 1 equivalent, but starting in 2016, everyone is going to be doing the meaningful use 2. And in 2017, some may choose to adopt the MU3 early if they wish, but basically, in 2016-2017, everyone will be doing meaningful use too. And you can see that on the calendar down below. The other change that's proposed in this is that starting in 2017, those who are attesting to Medicare for the first time will need to do a full year of attestation. Now, I'll be mentioning this a couple of times. But what this means is those of us right now in 2015, if we're doing a full year of stage 1 or had intended to do a full year of stage 1 or had intended to just do 90 days of stage 1, we're going to need to do a full year of stage 2 starting in January 1 of 2016. That's both for hospitals and for professionals. So again, you'll need to set your eye on the ball of what may be required for 2016 so that you're prepared when January 1 comes around. We'll talk more about that, the details, as we go on here. So the reporting period. In 2015, hospitals starting in 2015, so their first year, and continuing on, have a calendar reporting year. So, in other words, in 2015, this proposed rule is switching hospitals to a calendar year reporting. So they're actually 15 months in the reporting year for 2015. But they really only need to attest for 90 continuous days within that 15-month period. Professionals in 2015, again, any 90 days. That's for anyone regardless of the year of meaningful use. Now in 2016, it'll just be 90 days for those attesting for the first time, and as I mentioned, a full year for those beyond their first year of meaningful use. And then in 2017, everyone, whether it's your first year or not your first year, will need to report a full year of meaningful use. The only exception is those people who are doing their first year under Medicaid. And for those folks, they would be able to do 90 days. But if they're also subject to the Medicare disincentives or let's say the Medicare adjustments, they will have to do a full year anyway, even if it's their full year, or else be penalized. So again, if you have questions as I go through this, please enter them on the right-hand side, and I'll be happy to answer them as we go. Attestation. There are really no changes to the method of attestation in this proposed rule. The one thing many folks have found out is because they're planning on changing the requirements for 2015, they've shut down the Medicare attestation site. So they're saying no one can attest before January 1, 2016. The other change in this is that since everyone now is on a calendar year, everyone's deadline for attestation for the calendar year will be the end of February the following year. So for 2015, the deadline date will be February 29th, this is the leap year of 2016. Finally, Medicaid, providers who fall below the 30% level if they're a regular provider, or a pediatrician, it's 20%, the threshold. They can attest under Medicare to avoid the penalty without constituting a switch in the payment programs. Because as you recall, if you're a Medicare provider as an eligible professional, you're allowed to switch to Medicaid once, or if you're a Medicaid incentive, you can switch to Medicare once, but once you switch, you cannot go back. So in this proposed rule, in case your percentage dropped for a year, you could still demonstrate meaningful use to avoid the Medicare penalties without having to switch into the Medicare payment program. And there's advantages to that because there's more money in the Medicaid program than there is in the Medicare program. So incentives, this is a reminder. The incentives really are unchanged but winding down. There's nothing new here. This is just to remind you of where we are with incentives. Under Medicare, if you're just starting, 2014 was the last year for a professional to receive incentives. If they didn't start meaningful use in 2014, no incentives. Done. 2015 is the last year for critical access or prospective payment hospitals to receive incentives. The last incentive year is 2015 for everybody. 2015 for critical access hospitals and 2016 for EPs and TPS hospitals. There's a calculation behind it, but we won't go into that. But for EPs right now, the incentives are getting rather minimal. Medicaid, if you're just starting, 2016 is the last year for anyone to receive incentives if they're just starting it. So 2016 is their first year they're eligible to receive incentives. 2017, nothing. For professionals, 2021 is the last payment year, and you get a maximum of 6 payments. So with professionals, you don't have to get those 6 payments in sequence. You can actually skip a series of years. So if you started in 2011, you may skip a year or two if you fell below 30%, but you still can get a maximum of 6 payments, and you would still get the maximum amount. It wouldn't change the amount you receive. But the last payment you could possibly receive as a professional is in 2021. For hospitals, the last payment date depends upon the state. The states are given the option of dispensing the funds over a 3 to 6 year period after the first payment. But another thing about hospitals, unlike professionals can skip a year, any payment skipped after 2016 by a hospital ends their payment incentives under Medicaid. So this is nothing new. This is just a reminder of the way things have been. Penalties and exceptions also unchanged. All those who test for the first time any time in 2015 will not be penalized in 2016 or 2017. Now remember, the attestation site's not going to be open until January, so they didn't want to penalize people in their first year who were banking on attesting earlier and avoiding the penalty in 2016. So they're saying, okay, if you attest by January 1, 2016, regardless of whether you're a hospital or professional, we will not penalize you in 2016 or 2017. All who attest for the first time in 2016 will not be penalized in 2016 and 2017 if they attest before October 1. Now you may recall, previously if you attested 3 months before the last date, you could avoid the payment adjustment in the following year. Now again, since everybody is on the calendar year, it'll be October 1 for both hospitals and professionals. But that's just for 2016 because in 2017, they're suggesting it be a full reporting year, and there's no way you can attest early. So 2016 is the last year you could do it early in the year and avoid a payment adjustment in the following year. Other miscellaneous changes, state flexibility and meaningful use is not changed. And paper-based documents, I made a slight error here. I've read it more closely this weekend and previously. Paper-based documents will no longer count in numerator starting in 2015 except for one. Patient education materials will still count if they're delivered in paper format. At least it appears that way in the reading. It does not say in that one that paper does not count. So that's a good sign. So again, you've seen these 7 categories under Stage 3 meaningful use. Well, they're using these categories now for Stage 1 and Stage 2. They used to use the national priorities as the outline. Now they're using this as the outline. So we're going to go through all of the objectives kind of according to in the sequence of these bullets that you see on the page. When I've done presentations before, let me back up here a second. Every time rules for meaningful use come out, the sequence of required elements changes. In year 1, it was in one sequence. In year 2, it was another sequence. Now in year 3, it's another sequence. So what I've traditionally done when I've given presentations is I think about it, okay, as a provider, as a patient coming in, what's the first thing I do? What's the second thing I do? What's the third thing? And I try and do the presentations in that sequence. But right now I'm going to do it in the sequence in which it appears in the proposed rule, which may be kind of confusing, but that's the sequence that it appears. I thought it might make it simpler, at least for this presentation. So, the first one is protect personal health information. There are really no changes to this rule for Stage 1 or Stage 2. The only thing is that they expand it to also include the like jump drives or other devices that have personal health information up on them. Again, it's always been that way, but they're just making it clearer in the rules that you need to pay attention to that. That's the only change with protect personal health information. Drug formulary check. Okay, that was incorporated into Stage 2 ERX for eligible professionals and eligible hospitals. It was a menu item for Stage 1. So we'll see in a moment here. that it can actually be excluded for anyone who's stage 1 in 2015. So ePrescribing. Stage 1 is unchanged, but you would only need to do the 40% of permissible scripts. Stage 2 requirement in 2016 and 2017 for anyone in stage 1. So otherwise, stage 2 is completely unchanged. Now, again, the only thing about stage 1, again, is that you would just have to do the permissible scripts, 40% in 2015. You would not need to do the checking it against the formulary. Discharge ePrescription. That was a menu item for hospitals in stage 2. It didn't exist in stage 1. For stage 1 in the hospitals, it won't be required in 2015, but it is going to be a requirement in stage 2 in 2016 and 2017. In stage 2, it has become a required element, otherwise unchanged. So it's gone from being a menu item this year to being a required element. So if some people this year who are doing stage 2 in 2015 have decided to not to choose this as a menu item right now, is the way I read it, is with the proposed rule, you would need to do it as a core item. So you would need to start making sure that you get your outpatient discharge prescriptions from the ED or from the hospital electronically transmitted. But the 10% bar is not a really high bar to have to leap above, so I don't think that's going to be a hardship. Decision support, really unchanged for stage 1 this year, but next year stage 2 for everybody, and otherwise not changed. Again, the clinical decision support interventions can take multiple types. A lot of people think that they have to be pop-ups. A lot of people think they have to correspond with quality measures. Neither of those are true. They can be any sort of electronic health record kind of intervention, meaning flow sheet or an order set, a reminder in the corner, whatever, that helps you do the types of things you need to do for a patient that you feel is a high priority patient. It may be someone it's one of your quality measures. It may not be one of your quality measures if you don't have it to correspond with a quality measure. So it should be something that you can say, this is important to us because taking good care of these patients are important to us, and this helps us do that. You just need to be able to document that. Drug-drug-drugality interaction checks, unchanged for stage 1 and stage 2. That goes for the exclusion too. So if the professional is writing less than 100 medication orders, again, they would not need to do those. Computerized provider order entry. Again, for stage 1, they're not, in 2015, that would not be changed. So it would be either 30% of patients with any med or 30% of all orders would be entered via CPOE. But starting in January 1, they would need to do the stage 2 requirements, which are unchanged from 2014, where you're doing 60% of all medication orders, 30% of all laboratory orders, and 30% of all radiology orders must be entered using CPOE. There are exclusions if you write less than 100 of any of those particular order types. Finally, they did expand for meaningful use 3 the definition of who could enter orders slightly, but it's not been changed for the proposed rules for stage 1 and stage 2. And at the bottom of the screen, it describes who may actually enter orders for computerized provider order entry. Patient education. Now for stage 1, again, that was a menu item of greater than 10%. So it will still be, you can claim an exclusion for 2015 if you're at stage 1, that's what they're proposing. For stage 2, it's still greater than 10%. And in this instance, giving your patient papers still counts. So that's a good sign. Again, the denominator for hospital and for clinic are the unique patients, not per visit, but per patient. And exclusion is no office visits for hospitals and no office visits per professionals. And for hospitals, there are no exclusions. Online access to health information. There are a couple of measures under this one, and they've been split up a little bit. So this measure was the one that called DDT. People had the ability or provided access to view, download, or transmit their electronic health records. That one is essentially unchanged. For stage 1, it was now core. For stage 2, it's now core. And so for the proposal, it makes no change to this particular measure. What I have here is actually the elements that fall within this measure. And the reason I list the elements here is because in order for it to be able to count that a patient can view, download, and transmit their electronic information, it should contain all of these required elements. Now, there's wiggle room in some of these required elements, and that they do say in the language, if for some reason the information is not available or the field is empty, it can be blank. But there are some that are absolute requirements, and those traditionally have been medications, medication allergies, problems, and I think it's those three, maybe labs. I'm not sure if the labs were, I forget right now. So you can see, and this is just for your information, I won't read through them. The elements on the left for professionals, the elements on the right for hospitals, they're pretty similar. And this is where you'll see some of the things that have been deleted, like smoking status or vital signs or problem lists, that are no longer discrete measures that you need to report. They actually need to appear in online access in order for the online access to count. Now this is where I get confused, and this is where I'm going to, when I submit feedback, I'm going to ask for more information. Because how am I, if I'm audited, going to attest, I'll go back a slide if I can, how am I going to attest that this information has been available within the EHR within 4 business days? Is it a screenshot? Is it that a patient downloaded it? I mean, how are we going to be able to attest to that? And how are we going to be able to document it when the agency comes and the agency says, let's say, prove it? So that's just something I don't know that. I don't know that. And that's, I think, something that needs clarification. So this is the second measure on online access to health information. And this is where people actually view, download, or transmit their health information to another place. That was not a stage 1 requirement. It was a core requirement in stage 2. And it actually created a lot of concern on people's part because, how do I control what my patients do? Some of them don't have access. Some of them, don't come back. It created a lot of concern on the part of individuals. Now, there were exclusions, and you can see there are exclusions if the professional didn't create that information or if there wasn't good broadband access. Well, what they're proposing now for stage 1, again, it may be excluded because it was not included in stage 1, but starting in 2016, everyone's going to need to do the stage 2 requirement. But the stage 2 requirement will change with this proposed rule, and it's required that you attest that at least one person has viewed, downloaded, or transmitted their health information. So that actually makes it a relatively low bar. The other thing that's changed in all of these online accesses, and I had to double check this because I couldn't believe it, they changed it from 3 megabit per second broadband to 4 megabit per second broadband as your cutoff. Why? That one little bit I'm not sure, but all the other exclusions are exactly the same. Secure electronic messaging. Again, this is another one that caused concern because they're asking that 5% of patients email their professionals. Now, if you're on the call last week, you know that stage 3 is actually a much higher percentage, but it actually can include professionals emailing their patients. So in order to reduce this concern around the 5%, this is what they've done. Again, because it was not required in stage 1, you may exclude it if you're in stage 1 in 2015. But everyone's going to need to do the new Stage 2 requirement starting in 2016, and that is merely attesting that the capability is fully enabled. It doesn't say in the proposed rule that anybody has to actually use it, but that it's enabled. And again, the exclusions are unchanged except for the broadband increase from 3 megabits per second to 4 megabits per second. And that previous slide actually had a link to the broadband map. You can find out what you have within your community. Summary of care referrals. Okay, so the menu item in Stage 1 for 50% of referrals and transition care, summary of care was sent. In Stage 2, it became a core item where 50% were sent to other providers, 10% were sent electronically, and one or more had to be sent to a place with a different EMR, and it was a different system. So it wasn't like me sending it to my hospital, sending it to my clinic, and both hospital and clinic were owned by the same organization. It was just that they had different EHRs. That would not count. So what they're now proposing, again, Stage 1, they may claim an exclusion for this, so they don't even need to do any referrals or transitions, because in this particular instances, they're not going to be counting the paper. As best I can tell, they're dropping that requirement. They're requiring in the next year, however, that you do only the Stage 2 requirement. And that is, the summary of care is created with certified EHR technology, and greater than 10% are electronically exchanged. That doesn't mean that you sent it. It could mean that it was pulled, it was pushed, any number of ways that it could have been gotten from one place to another. So there's greater flexibility in the definition of it being sent. But again, it's 10% need to be sent, and otherwise the denominator and the exclusions are unchanged. What's interesting again is that this is the other measure that measures your use of things like problem list, medication list, allergies, etc. So this is the summary of care referral elements are the same for both hospitals and professionals. And again, I'm just listing the elements in the summary of care referral. They are all theoretically required, but there's wiggle room in the statement when they say they're all theoretically required. Again, if there's no information in there, or if the field is blank, you will not be penalized for that. So it will still count, but there's still the core ones of meds, allergies, problems, and I believe labs. So again, I put this up there for your information because it's going to show some relevance later on. And it's going to show relevance for you too as you're working with your providers. Medication reconciliation. Again, for Stage 1, that may be excluded because there was a menu item in Stage 1. The Stage 2 requirement will be for everybody starting in 2016, and it's essentially unchanged from the way it is currently. 50% of transitions of care you need, or relevant encounters, you need to do you need to reconcile medications. Now again, there was an FAQ released probably 2 years ago now, that stated if you had a policy that all of your ambulatory encounters were relevant encounters, that you could then select all of your encounters in the denominator as opposed to trying to figure out which ones were referrals and transition care and which ones were not. Because that actually created an additional workflow element for some providers to try and find out from a patient, have you been to somebody else, in order to be able to check the checkbox so that it counted as medication reconciliation. So again, that FAQ showed previously, I can't see any reason why it was not omitted or changed for Stage 1 and Stage 2. Something to be aware of. So now we get into the Public Health and Clinical Data Registry reporting. This is the last group of measures, and this applies to all of them. Now, the objective for these is the active engagement with a public health agency or clinical data registry to submit electronic public health data. Now, they use the term active engagement, and active engagement shows up on all of these measures. So I thought I should define active engagement here. there are three types of active engagement. The first one is you've completed registration to submit data. So if you've sent in an application to submit data within 60 days of the start of your reporting period, you're doing well. And you're still awaiting the invitation to test and validate. So if you've sent your request in and have got nothing back, you're good to go. If you get something back, that's the second one, testing and validation. If you respond to the request to test from that agency, you have to respond within 30 days. So if you get a request, you're in testing and validation if you respond to these requests within 30 days. And then you're in the testing process. And finally, the last level is production, which is active submission of data. So you actually have three levels. Number one, you've sent in a request. Number two, you're in the testing process. And number three, you're in production. So those are titled active engagement. There's still an exclusion for all of these. If your agency with which you want to exchange is incapable of doing it at the start of the reporting period, then you're not held accountable for it. So again, if it's not there at the start of the reporting period, that's in the proposed rule. So let's go through the objectives. There are there are actually six of them here, five for professionals and five for professionals and six for hospitals. And this lists the maximum number of times you can do any particular one. So for immunization, syndromic surveillance, and case reporting, you can only count one of each of those. However, for public health registry and clinical data registry, for those eligible professionals, they can do 3 in public health and 3 in data registry reporting. Hospitals can do 4 of each if they choose. And for electronic lab reports, it would just be 1 for hospitals. So as you can see, under public health and clinical data registry, you can be submitting to multiple registries or be engaged with multiple registries to submit, and those would count. So for professionals in their first stage of meaningful use, they must choose 1. And then from 2016 on, they would need to choose 2. For hospitals in their stage 1 of meaningful use, they need to choose 2. In stage 2, or for everyone after 2016, they would need to choose 3. So let's go through the particular options. Submit to an immunization registry. That one is there before. Again, the only thing that's changed is active engagement, but they're also now saying receive immunization forecasts and histories. So again, if your agency is not capable of sending you forecasts and histories, then I think you don't need to be concerned about that, because again, that has to be available at the beginning of the period. But you do want to be involved in active engagement in doing it and testing it. Denominator and exclusions are otherwise unchanged. Syndromic surveillance. Again, the only thing that's changed is active engagement. Otherwise, it's the same. Case reporting. This one is a new one. It wasn't specifically called out. Again, it's active engagement with a public health agency to submit case reporting of reportable conditions as defined by the state, territorial, and local public health agencies to monitor disease trends and support management of outbreaks. Again, it's a yes and no denominator, or yes and no attestation. And there are exclusions if you do not diagnose reportable diseases for which data is collected, or there's no public health agency with the capacity to receive this. So this is specific case reporting. Now, cancer registry was one for professionals that was in stage 2. They called out cancer registries previously because they thought they were the ones that were the most well-developed, so they wanted people to pay attention to them and begin to report to them. But actually, they're folding that into the other registry, so it's no longer called out individually. It's not specifically identified. So these are the 2 registries that we have now. We've got a public health registry, and again, you can do more than one of these. And again, it's active engagement with a public health agency to submit relevant data to the public health registry. Test yes or no, and again, if you don't diagnose or treat the relevant diseases or there's no agency capable to receive it, you have an exclusion. So those would be public health agencies for public health reporting. So the other one is the clinical data registry. They really split the registry reporting into two. And this is the same thing, submit relevant data to a clinical data registry. And in this particular one, they define it, and I imagine it would be true to be defined in both of them, but they define this as a record of health status of patients with relevant diseases and the care they receive over time. So as opposed to the case reporting where you say, oh, so-and-so just got this disease, this is one where you say, this patient has this disease and this is how they're doing over time. So it's for tracking patients with a particular disease. And the denominator is yes or no, and with the exclusion if you don't treat anybody or there's no registry capable of receiving this information. Reportable labs is the one that's specific to hospitals. Again, it's active engagement and otherwise unchanged. Can you provide some examples of public health clinical data and case reporting registry? They actually say in the rule, public health data registry could even be immunization registries, but they're still keeping that out. So again, public health registries are any public health information that they want to that they deem is appropriate, where they want to track over time. It can be AIDS. I don't know the specifics on that, but again, it's anything that public health wants to pay attention to because it can affect the population. As I understand, cancer is one of the public health clinical data registries because the public health in the state do track cancer patients, whereas there may be other registries that track patients with other specific diseases. And again, the case reporting registry could be public health. It could be another agency where a disease of importance to the specialty or the individual, they wish to have it reported whenever an occurrence occurs. So that's more a recording of an occurrence. The other ones are more of a recording of ongoing care. So thank you for asking that question. Okay, I think we covered reportable labs. Now, here we come to the ones that are not included. These are the ones that, again, show up in online access and summary of care for the bulk of them. Demographics. They need to be in online access and summary of care. Vital signs. Again, appear in online access to health information and the summary of care. It is no longer separately reported. Problem list, same thing. No longer separately reported. And again, I reiterate, at what point in time do we pull a trigger to take a picture in order to be able to document that it's been done in case we're audited? I don't know the answer to that. Medication list, same thing. Online access, summary of care, otherwise not reported separately. Allergies, same thing. Smoking status, also same thing. Family health history. This one's not reported at all. It was a menu item in stage 2 where 20% had to have structured data for first-degree relatives, and now for stage what they're proposing is that it not be reported and it isn't an element in any of those elements that I showed you in the summary of care or electronic access to health information. Family health history is not mentioned. And if it were topped out, it may have been topped out because, again, the people who were reporting it, or the people who were reporting it were the ones who were doing well in it. The people who didn't report it didn't have any information in family health history. It may be not appropriate to include that for people in specialties that really don't care about family health histories, which, there may be many. But, again, it's not measured, not reported at all. Advanced directive, same thing. Not measured, not reported. I would imagine it would be of interest to the hospital to be able to collect this information, but it's not a required element, and it's not specifically reported at all for meaningful use. Nor is electronic medication tracking in the hospital. That's not reported at all. and it's not an element in summary of care or electronic access to health information. Electronic provider notes. Now, this is an interesting one, because when you look in all the fields that appear in the online access to care and in the summary of care, the only place that I can see where you would want, where providers would need to enter information would be in the care plan field in the online access. So I would think that they would have a care plan field for each potential visit, and then for a hospital would appear under the discharge instructions and or the reason for referral under EP. Otherwise, again, provider notes is not reported separately. And again, editorially, I had a concern with this because when I visit some of the smaller facilities, and especially the smaller hospitals, where physician notes on rounds and physician notes are typically written, you therefore have this issue of some of the information is in the electronic chart, some of the information is on paper, and if you're trying to figure out what's currently going on with the patient, you don't know where the source of truth is. It could be in the EHR, it could be on paper. And if you're trying to assess someone remotely, if let's say you're on call and something's going on in the hospital, you may not be able to read the other provider's note if it's on paper without coming in. So I'm concerned about this one, but that's a personal concern which I thought I would share. Imaging results. Again, remember you used to have to show the imaging results need to be available within the EHR so that providers could actually see it if they wanted to. That's no longer reported and it's not an element. So again, that one is no longer going to potentially be a requirement for stage 2 or any stage. And incorporate lab results. That is a mandatory element in online access and summary of care, but again, it's not reported separately. So again, for some places, they've gone through a lot of pain to enter labs in manually into the EHR. So because they didn't have an electronic connection with their laboratory, they would just get faxed lab results. So for those people who are in that sort of a challenged environment, this may provide them with some relief, or it may reduce the amount of information that's actually discoverable within an EHR. Patient list, not reported. However, it could be considered an element of quality measurement, because if you're looking at the diabetes patients and you're doing things in quality measurement, you are going to be looking at patient lists. So this one is not measured separately, but it probably is the one that you think that is quite redundant. Now, electronic lab results. This one was a challenge for some of the hospitals. Now, what this one was is that if a professional, let's say a doc in town, ordered his labs at the hospital, and the doc in town had a different EHR than the hospital did, the hospital had to result those reports to the doctor electronically so it could be incorporated into his EHR. Now, again, this measure is not required, so the hospital would no longer have to set up a interface to do that. They could now just fax them the information or send them a PDF and no longer have to set up an interface with that doctor to send back the lab results. So that's an interesting one too. And finally, I think we're almost to the end of the ones here. Clinical summaries, again, these potentially appear in the online access plan field where it says includes goals and instructions. So I imagine that would be the clinical summaries. That was the ones that professionals needed to do. Paper, again, is no longer tracked, no longer reported separately. And interestingly, clinical summaries were the ones that caused some of the most challenges for ambulatory providers to give to their patients or get to their patients. So we'll see if the number of clinical summaries produced begin to decline. Patient reminders are also not reported and not required. So again, this is a summary of the ones that have been eliminated as separate measures, just a listing of them. And this is a slide that shows the changes to stage 1 for 2015 and 2016. The first column is the way it was in or the first two columns are the way it was in 2014. The next two columns are the way it is in 2015 now, and you can see the exclusion for the drug formulary. And the third column is the way it will be for stage 1, which is really stage 2 in 2016, 2017 for any of those folks who would have been in stage 1. And then we have the items that were deleted, and it identifies where I believe that they would be showing. And the changes to stage 2, same thing. Stage 2, 2014, in 2015, and stage 2 in 2016 and 2017. And really, I could have eliminated that third column because stage 2, 2016, 17 is the same as stage 2 in 2015. Oh no, there is a change. There is a change. There is an increase in number of the public health reporting for professionals from 2 of 5 to 3 of 5, and hospitals from 3 of 6 to 4 of 6. So there is a change between stage 2 in 2015 and stage 2, 2016. And these are the ones that are deleted, especially where they would be showing. Okay, for quality measure reporting, we're using the same method as in 2014. Again, as a reminder, 2015 is any 90 days in the calendar years. For hospitals, they have an additional 3 months. So they have all of calendar year 2014 and the last part of the calendar year 2013, giving them 15 months. So reporting can be more than 90 days, and it also doesn't have to correspond with the objective reporting period. So you could be doing your quality measures early in the year and then do your objectives later in the year or vice versa. Again, 2016, it's a full reporting period for everyone, regardless of your year of meaningful use. So again, circling back, this is the link to the HTML document for the proposed changes to stage 1, stage 2, and also the link to where you can submit your comments on the changes to stage 1 and stage 2. So with that, again, we have another question. Please repeat where the handoff and slides will be found. We'll do that at the very end, if that's okay. So again, just as a reminder, the Lake Superior Quality Improvement Network has a meaningful use consultation services. So we help you out with meaningful use 2 and 3. You would need to, if you're not a meaningful use 1 user, you would still need to use your extension center. We provide education and technical assistance to help you with your attestation of meaningful use and your quality improvement processes. We also have learning and action networks, which allow you to share what you're doing with each other and learn best practices from each other. And the services are free of charge. All we ask is that you sign up. And finally, these are the contacts from the states of Michigan, Minnesota, and Wisconsin, along with their contact information if you want assistance with becoming a meaningful user of electronic health records. So with that, I will close, see if there are any questions. But first, Alex is going to tell you where you can find the slides.
Yeah, that's great, Paul. You can find the slides on the Lake Security Quality Innovation Network's website or LSQIN.org. And eventually, I would say those are going to be up within a week to 2 weeks. So be sure to check there at that point.
So any questions at all? And while you're pausing, do we open the lines for questions? Is that how it works?
We're going to hold off. Please submit your questions via the chat box.
One thing I want you to be aware of, and I want you to make your clinics and customers aware of, is the fact that these rules are proposed. That does not mean that what's written in these rules will be what the rules actually wind up being. So, a word to the wise is to shoot for at least what the requirements are now, and also, if you're at stage 1, shoot for getting ready for stage 2 starting in January. Now, some of these may go through, and some of the rules may be somewhat relaxed. But again, don't count on it, because although in previous years, the final rule has been very similar to the proposed rule, there have been changes. So, a word to the wise is don't take your pedal off the metal. Keep going full steam ahead. with effective use of electronic health records.
Dr. Kleberg, did you say when this final rule is expected to be out? I didn't remember hearing that.
They've not stated when the final rule is expected to be out, but I would suspect it's probably not going to be out sometime until September or October. It may be out earlier, but there will be, I'm sure, a lot of comments for them to go through. And they read and respond to every single one of the comments.
All right, well, Dr. Kleberg, thank you very much for the presentation today. And as we're waiting for the final questions to come in through the chat box, should there be any, just a friendly plug to please take the evaluation after you leave today's webinar.
So here we have a question. If this is the first year of testing for eligible professionals stage 1, the reporting period is 90 days period from January 1, 2014 to December 31st, 2015, correct? Well, wait a second. No, it's from January 1, 2015 through December 31st, 2015, if this is their first year of testing for meaningful use stage 1. So the reporting period is 90 days, and that may have been a typo when you said January 1, 2014. It's actually January 1, 2015. So it is really unchanged this year for anyone attesting to stage 1 meaningful use as an eligible professional. The only thing that's changed may be some of the minor requirements. We've also had a hint on the chat box from one of our staff on how you can find the information on the LSQIN website. And you know, we had this conversation last time. If you think your question might be a dumb question, you could always say, you know, I've heard people ask this question. Would you mind elucidating this? Somebody else had that, and there are others that may have that same question. Because it's sometimes intimidating to have your name put up against all these questions. And you don't know who's going to say, oh, so-and-so didn't know that.
You know, that's a good point, Paul. You also have the ability to just submit your questions to Dr. Kleberg himself, should you want to remain anonymous. Hey, here we go.
When you say that they are deleted for 2015 and 2017, when does that start? Yes. That is still just proposed. You're correct. If they delete it, you wouldn't be reporting it at all for 2015. And then the way I'm reading it, because the attestation site will be changed, you would not be attesting to those elements that have been deleted. Oh, they're really coming in now. Good. Can I attest now for providers that have already shown 90 days? No, you cannot. You need to wait until these changes have been approved, but even more so because they're in the process of making these changes. That website is shut down for the federal government. I mean, the Medicare site is shut down now. You could attest to your state. The state may still have their attestation site up, or if you're an extension center that needs to get attestations in order to be able to claim credits, you can go through the MU3 tool. Any of you who are extension centers know what that means. You could potentially go through the MU3 tool with them so you can gain credit for their achieving meaningful use. Oh, and that last question looks like it appeared twice. So, yeah, sad to say, we're stuck, which would mean that, you know, you cannot attest until sometime after January 1, regardless of your 90 days. So clarification for stage 2 public health. Again, let's go back to that slide if I can get there quickly. I'm not going to get there quickly because I don't remember where it is. two public health measures for 2015. In 2015, if you're in stage 1, you do one measure. If in 2015 you're at stage 2, well, again, it depends upon whether you're a hospital or provider. Oh, looks like I may have an error up here. Let me see. 2015, choose 1. 2016 on, choose 2. Stage 2, choose 2. Okay. So in 2015, stage 1, everybody chooses just one as a professional. For stage 2 and 2016 on, you choose 2 of them. That's as a professional. For a hospital, you choose 2 in 2015 if you're at stage 1. You choose 3 in 2016 on, or if you're in stage 2. I see that. Do you anticipate a longer period for actual complete attestation? Historically, CMS has extended it to March. You know, that's really a good question, and one of the things that a number of people have been concerned about is the fact that with all hospitals and providers and everybody all testing at the same time in January, it's going to create a logjam. And a number of us have actually asked in our response to stage 3 that they extend it, but that's something that I think we'll need to pay attention to, because yes, that attestation site has gotten so clogged that people were staying up in the middle of the night to do the attesting for their company. Now again, the way CMS typically works is they don't extend it to the last minute because they don't want to extend it and then have everybody wait for the new last minute. So they try and encourage people to go along with the process. We're getting payment penalties for EPs that didn't see patients in the previous year so don't have MU numbers. Should we be attesting for EPs that have no patient visits? Or what do we do to prevent payment penalties? Is there anything we can do? This is a known issue to me. I don't know if it's a known issue to CMS. And I have a contact that's pretty high up within CMS, and I'm going to raise this issue to see what the options are. I don't want to wait until the proposed rule goes through, because there is an excuse for those folks who are in their first year of practice. Well, there needs to be something similar for those who have been out of practice and decide to come back, or for those who have been a hospitalist and haven't been in ambulatory settings, and now all of a sudden go into ambulatory settings. We should not be penalizing them. Finally, could you give some broad guidelines for responses to the proposed rules? How in-depth, data-driven? The best thing you can do, and this is a really good question, thank you for asking that. The best thing you can do is you start out when you look at, they want to know the things you approve, or they want to hear the things you like, so that's good, and that can be a quick answer. But for those things that you're concerned about, state your concerns and state your concerns why, but then end it with recommendations. What do you think may be the best solution for that? So if you have data in the reasons, give the data. If you have depth, give the depth. They read everything, but in the end, the best thing to do is come up with a recommendation on what a proposed solution would be. Okay, I think with that, we're at the top of the hour, so to be good with everyone, we'll probably need to end right here, so thank you.
Yeah, thanks for that, Dr. Kleber. It looks like we opened the floodgates there at the end. Just to remind everybody, we do have Dr. Kleber's email address and all of your state's email addresses should you want to get in touch with your Quality Innovation Network. With that concludes today's Burning Issues webinar and the series. We look forward to seeing you on our next one. Just another plug to please take the survey after you've left today's webinar. Thanks, everybody. Have a good rest of your day.
Bye.